as an example, you can have a multivariate pattern that's very abnormal, but the univariate measures within it can be all within normal range. If your brain has the left hemisphere a half a z-score high in delta, and your right hemisphere is a half a z-score low, that pattern is actually highly significant. You've got a functional deviation there hemispherically, and there's something different between the two hemispheres that's significant, even though the univariate measures aren't outside normal limits. So you need to look to the patterns in the EEG and not simply depend on a univariate database to tell you when something's not right. We're going to look at the raw EEGs today. And I always start with the eyes open and take a look at the EEG with the eyes open. So what we basically have here is a referential montage to linked ears. And if you look, the frontal electrodes are up in the front and the occipitals are down in the back. And it's cutting across from F7 to F8 and T3 to T4 and T5 to T6. So this is a transverse montage. It's referential and it's to linked ears. And as we start to go through the raw EEG, you're essentially looking at eye blinks up in the front. Now, if we were to process this, we would end up having to cut those out and throw away the EEG and the eye blinks. And obviously for the first bit of the EEG here, this is pretty much all throwaway. And then we see this widespread event. Now, Laplace was a mathematician physicist who discovered black holes, and he happened to also describe electrical currents in spheres. And in his view of things, the currents on the surface of a sphere have to sum to a zero. So you can't have everything going in the same direction at the same time. And when we look at this widespread discharge, it looks like a lot of this stuff is taking a dip at the same time and making a bump at the same time, and that this isn't physically possible in the real world. So we know we've got something wrong with how we're looking at the EEG here. Our perspective can't be correct because this can't happen. But if we switch our perspective by changing our montage, we'll have a different look at this. So I'm going from a linked ear montage to a global average, Laplacian generalized. Every electrode's in the reference. Sometimes these are referred to as a reference-free reference. We're going to be looking at the source at each site as a current source density. Now, the event that was widespread, where is it? Well, in fact, it isn't there widespread, but it is here in the temporal lobe. What was happening in our previous perspective of this was that the temporal lobe source of this was contaminating the ear reference. And the ear reference was giving us a widespread distribution when it really was only coming from the temporal lobe. So what we've got here is, in fact, a change in function in the temporal. And when we look at, this is a fifth of a second between the pale lines and 1 second between the dark lines. So if we look at it in this fifth of a second where it happens, we see a wave and a half. So this would be about an 8 hertz rhythm, but there's some of it that doesn't quite hit the next peak, so it might be just a little below 8 hertz. So we can expect, as we look in the raw EEG, kind of a slow edge of alpha in the temporal lobes, and this is an F8 T4 and a little bit at T6, you can see. And sometimes it helps to kind of match them up to see how much of it ends up being similar. But you can see that there's a similar rhythm running through that entire side. Now, it's not only on that side. Here we have an event of it that pops up a bit on the other side as well. So we've got to look at the raw EEG here. And as we're going through, we're seeing slow waves that are in the temporal area that are independent left and right. And we see a very slow alpha frequency. So one of the things in EEG, when you see a slow wave or two and then they go away, this is a clinically significant pattern. And in our laboratory, if the doctor sees this and it's written up, these findings of intermittent temporal slow waves that are independent like this, they're not persistent. If this was an ongoing, always there slow wave in the temporal area, that's a focal slow wave. But what we have here are bitemporal transient slow events. And in our lab, these are generally described in the following manner, that though these findings may be seen in asymptomatic individuals in this age group, temporal slowing is generally thought to be associated with cerebrovascular insufficiency. So what we've seen only when we get to the correct montage is that we've got a clinically significant pattern of independent temporal slow waves, right and left side. You know, here's a slow wave that's distinctly present on the left side. Now, you know, some people would say, well, you know, there's an eye movement, and you know, it might be related to this, and you know, you'd have to de-artifact this and then analyze it. Well, the artifacting, it's actually fairly easy with some of the modern tools. I'm going to do an ICA de-artifacting to just take the eye movements out and leave the EEG intact. Now, if you do this, you can't compare these results to a database that doesn't have these techniques available. To start with, what you see right now is a PCA, and you can see the topographic distributions are kind of spotty, like a badly inoculated Petri dish. The PCA is only good for Gaussian distributions, and although some people argue that the EEG is Gaussian, it's actually not, and even if you just said, oh yeah, the EEG is Gaussian, artifacts are not. So eye blinks, for instance, aren't normally distributed. And what we see is now that the ICA has been completed, the distributions are now spatially fairly distinct. The top one's automatically selected. This is the eye blink component. This is the raw EEG with everything in it. This is the EEG minus the component. So the eye blinks are essentially being removed at this point. And as we scroll through the EEG, you can see the eye blink, including the inverse of this data. You know, it's going up in the front and down in the back at this point because the dipole is rotating. So it's taking out the front and back content. It's basically it's zeroing out this component. Now, I can pick other components too, and on occasion you'll see a strong lateral eye movement or some other meaningful component that you need to take out. But this is now minus the eye movements. And you can see, well, if you can't see that there's still temporal slowing here, you need to see your optometrist, not your neurologist. So we've got an EEG that's full of independent temporal slowing. Now, the EEG is pretty well cleaned out. We've got a residual muscle tension running through in a kind of an odd location, F4, but that's not that big a problem. We can kind of read around that little fast buzz, as we're looking at the EEG. But let's discuss cerebrovascular insufficiency, which is, again, the intermittent slow events that we see temporally. This could be the heart having an irregular rhythm, not pumping efficiently. PVCs, PATs, bigeminy. I mean, there's lots of cardiac rhythm things that can end up doing this. You can also have carotid blockages, the actual plaque buildup in the carotids and vasculature generally that can do this. And as such, those are cerebrovascular insufficiency sources. And you have to look outside of the head to see those. Now, there's always the possibility of within the cranium, cerebrovascular insufficiency sources, but those are really super rare. Typically, this is cardiogenic or carotid and vertebrobasilar artery related. And those can be tested. Obviously, the EKG for the heart rhythm and left here, run this full EEG file through a Fourier. And at this point, we see this is the background alpha peak, and our frequency the frequency is going to pop up here, and the amplitude will be popping up here, so you can see them numerically. This is an 8.5 hertz peak, but the range of alpha drops all the way down to the 7 hertz range before it disappears. And it really doesn't have any content in the alpha band at 10 and above. So the range of alpha going from essentially 7 to 10 is a slightly slow range, even though the peak is acceptable for age 70. But the range is slow. So the alpha here is slowed. But you should also see within this distribution that we have the slow edge of alpha with a prominent peak right temporally, and we can map that. We can see this is at 7.5 hertz, 7.6, 757. If you want to, come out to a tenth of or a hundredth of a hertz resolution. But you basically can see the slow alpha is distributed temporally. The dominant alpha is distributed more in the back of the head, but it also has temporal power. The slowest edge of alpha probably has, I just picked the edge of this curve before it disappeared. You can see even below 7 hertz, we've got temporal content in the distribution. So the slow edge of alpha is a bit too slow, and the slow edge of alpha is distributed temporally in areas that are typically seen in vascular change, ischemia. The slow edge of alpha has a little peak, at, an increase here at 6.8 hertz even. And there's even slower content that's not just the high rise of the slow edge of the spectra. And that slow content ends up being seen in the frontotemporal areas. Again, that's not lateral eye movement. These are slow events in the temporal area associated with cerebrovascular insufficiency. Now, if you looked at the and you didn't have the experience to say, oh, that's cerebrovascular insufficiency when you see the pattern, don't be terribly surprised. It's not. You have to have the experience to see it, but you also have to have the licensure to be able to call that. And working with a neurologist or electroencephalographer to sign off on your raw EEGs is sometimes quite useful to take care of some of these medically significant features like this. So in this case, we basically have in the eyes open, an indication of cerebrovascular insufficiency with temporal slow alpha. That's probably related to ischemia. The American Academy of Neurology approved QEEG as a way to assist in assessing vascular issues in the EEG. Above and beyond the EEG, the QEEG provides value according to the American Academy of Neurology. And they're very current position papers showing that essentially the slowing of alpha can end up corresponding with ischemic change in the brain. So we're probably looking at a vascular change here, potentially vascular dementia, given how slow some of the content is. Now, we've only looked at the eyes open. Marilyn deserves to have her eyes closed looked at as well. Now, to treat it equivalently, we're going to switch immediately to the same montage. And at this point, one thing strikes me. First of all, with the eyes closed, you expect more alpha. And we've got an increase in the rhythmicity in the back of the head here. But I see really stable alpha up front. Every time I see the alpha peaks up front, they line up. Now, in the back, sometimes the peaks line up and sometimes they don't, because the back of the head here is busy doing stuff. It's phase stirring as the phase is disturbed by function. But the frontal lobes are sitting there like a bump on the log. The phase is absolutely stable up there. When I see alpha in the front, the phase just lines up every single time. Now, it's not in phase with respect to the back of the head. I mean, it's going up in the front and down in the back at this moment, so it's real. It's not like this is an artifact like Laplacian physics is being violated somehow. But the phase in the front, as I scroll through, when I see the alpha content up front, it's really very much in phase. And again, in the back, it's being stirred around in phase. Sometimes they line up and sometimes they oppose. So we still see temporal irregular slowing and the temporal slow alpha features, but the alpha up front is extraordinarily stable. And phase stability is coherence. So we expect the coherence to end up being high when we look at the processed files. But again, the temporal intermittent slow content here is clinically abnormal and needs to be dealt with appropriately. I mean, this is a vascular issue, and if there's nobody really on top of that, you know, you can end up having problems from the heart rhythm causing more significant problems. So that if your client's not currently being followed for cerebrovascular insufficiency evaluations of cardiac function, they need to have that looked at. Sometimes they've got their blood pressure controlled excessively and they're hypotensive. But whatever's going on is creating intermittent temporal slowing. If this was continuous, we'd say it's a white matter problem, but you can see it's there and then it's not. You know, the temporal lobe basically doesn't have that slowing now, and it does over here. So this large field slow wave that's running through the temporal areas. And again, you can see how T5 and T3 kind of nest. The waveforms have a phase relationship. This is the field to it. And the slow waves all the way up at F7 also have the same nesting. So the slow wave that's happening here is all the way from the F7, T3, T5, or in modern nomenclature, F7, T7, P7. That entire side, that entire rim ends up having it present on that side at that time, and independently, again, it'll end up happening on the right. So, and sure enough, here's a nice independent right side. So the independent and synchronous, bitemporal, just 1 or 2 wavelets of slowing like this. And again, it can be seen in people that are asymptomatic in this age group, but it's thought to be cerebrovascular insufficiency, and that's something to follow up. We can look at the processing on this one. I'm just going to run the entire EEG. Any eye blinks or whatever's in it is going to stay in it. It's actually pretty clean. You can see the temporal features here. This is at 7.5 hertz, which for an alpha peak is too slow. The dominant peak at 0.2 is 7.5 hertz, which is too slow. The databases would start to call these theta, and it would tell you there's too much theta. And when things are tuned so it's outside of the expected range, you're going to get some really strange things in the database. If this alpha just nudges up into the alpha range, it'll end up having a lot of the coherence and everything suddenly declared much more normal by the databases. But you can see we've got slow alpha in the temporal lobes. The overall alpha peak is slow. And for age 70, this is too slow. This, you expect statistically some slowing of the background with age. However, this is too slow. The saving grace for cognitive function here is that at PZ, we have the dominant peak up just about at 9 hertz. So the sensory integration area is still got some reasonable tuning to it, but the slow content in the temporal lobes here again points to the likely vascular source. The coherence, I'm going to pop up the average coherence, and for those of you who don't look at the actual raw coherence values, they go from 0 to 1. And as a rule of thumb, when you get above 0.5, you're starting to get an excess coherence. And you can see the peak here at that slow edge of the alpha band is at 0.6, which is at 7.57 hertz. And we can map the coherence pattern, and you can see that hypercoherence frontally in the EEG. You expect some coherence in the alpha in the back of the head. So a z-score, this is going to be more acceptable, but this is going to be an outlier in coherence. So we probably have an affective regulatory issue going on as well. Frontal lobe hypercoherence like this in the alpha band is usually a marker for an affective regulatory issue. And the slowness of the alpha here is identifiable. Now, alpha hypercoherence frontally generally responds to an SSRI, but if it's slow like this, you need norepinephrine to speed up the alpha. So an SNRI would be more appropriate. And perhaps even more specifically, rather than even focus on the SSRI, there's a fair amount of information now. In fact, there's a conference on pharmaco-EEG coming up this next month in Europe. And what they found is that the slow alpha like this ends up being not a good responder to the SSRIs. And SNRIs don't really quite get it either. So a specific norepinephrine reuptake inhibitor like Strattera actually speeds up the alpha and is perhaps a good match for this. And the Brain Resource Company has been doing quite a bit of work on that and have shown the slow alpha hypercoherent frontal pattern like this to be a real positive Strattera responder. And you don't even find Strattera in the list of things that you would consider if you diagnose this as depression. Strattera doesn't pop up to the fore on meds for depression. However, it's something that speeds up alpha, And the BRC has found this to be quite effective. Neurofeedback-wise, obviously, we're going to need to speed up the background alpha here, which is a brain brightener. And I'm suggesting also, obviously, you'd want to look at cardiac function and cerebrovascular sufficiency-related things like the cardiac rhythm. I actually had a coworker that had his EEG and QEEG done, and the doctor gave the, cerebrovascular insufficiency comment, but he wanted to have his Q looked at. He wasn't really looking at the EEG, so he didn't even open the doctor's report. And he had a dizzy spell, and he went in, and they actually looked at his EKG, and they took him in, and they put in a pacemaker. And he had cerebrovascular insufficiency based on the EEG, and he actually had a cardiac rhythm problem. He was skipping beats enough that he had to have a pacemaker put in. And the EEG on follow-up end up being normalized. So these transients of the temporal lobe are important. Anyway, that's one that we've gone through front to back here. And we've got another one here. It's a 17-year-old. And we've got an eyes open. And the beginning here, the amplifiers are just kicking in, and the filters are just kicking in as well. And right now, the European filtering here is the default. And if I put the 60 hertz filter on, it doesn't really change much of anything. This was probably recorded with a 60 hertz filter on, and we can't recover it by turning it off. And that's that's an issue that's got to end up being addressed in the next version of the Discovery software. The medical standard says you've got to be able to recover the raw EEG, not the filtered EEG the way you looked at it, but the raw EEG, so people can look at it, from scratch. But at this point, we do see the eye blinks. The EEG at normal recording sensitivity actually has some buzz of faster activity, beta frequencies in it. But CZ is particularly got a slower feature. Now, remember the last time we said when you start to see stuff that's in line everywhere, that's an issue with respect to the reference. And you can see the entire EEG has a slow dip here, and that little blip here. What we've got is, in fact, an ear reference issue. If we get away from the ear reference, the common, everything looking kind of halfway similar, like this, will all go away, and we'll see it a little bit more clarified. Now, CZ is distinctly the source of dominant slowing. And yes, we can see that there's faster, buzz scattered through the EEG. Eye blinks are up in the front, down in the back. This looks like real EEG now. And not all channels look like they're dancing together either. So when we corrected the montage, we basically take a clean look at things. Now, there was a slow wave that was here. What's the slow wave? Well, that temporal source here was, in fact, the source of an ear reference contamination that contaminated the entire EEG. So we're away from the ear references, and the EEG here has some slow content at the vertex intermixed with faster activity. And the faster activity has a sinusoidal waveform, and it's not everywhere at the same time. This has what's called physiologic distribution. So this isn't just a simple medication effect. And there, for instance, a benzodiazepine, you can get a beta buzz that's pretty much everywhere. And you don't really see physiologic distributions. The slow content dominant at the vertex, we get a little bit of slower content here in the F8 electrode area, and this may be related to transverse eye movements. There's some eye movements going on at that point, and we can take the eye movements out fairly cleanly, and that'll clear any of that up. We do see, even though the eyes are open, we do see some of the background alpha. Some of this is, you can see the peak here is just before the line, but 1, 2 plus, so this is just over 10 hertz, and some of this is, just at 10 hertz. So the frequencies can be estimated as you're looking at the raw EEG. This alpha-like activity here that's slightly faster is probably representative of mu. And mu is a normal variant neurologically, meaning that it's alpha-like in its activity, but it doesn't indicate that there's anything neurologically wrong there. There's no lesions, no tumors, no strokes, no seizures. The presence of the mu is a normal variant neurologically, but it functionally means that the mirror neuron system is disengaged. Now, the alpha kicks up here to the extent that it almost looks like we've got an eye closure or something. But as we go into the EEG further, it looks like the patient basically is less attentive, and that we're getting surges of alpha even though the eyes are fairly obviously not closed. Getting a lot of eye movement at this point, but even in between all this eye movement, we're getting a sputtering of alpha. So within 152 seconds, the patient went from eyes open and attentive to eyes open with some alpha popping up in the background. In Europe, they have a approach to looking at the EEG called a vigilance model. And for them, they like the eyes closed recording to last a minimum of 10 minutes. Now, obviously, that's not 152 seconds, and this isn't eyes closed. But the reason that they want that continuous without cuts cut out of it to clean it up is that they want to look at the ability of the person to maintain vigilance and just to basically stay present and focused even though the eyes are closed. And there are some people that have real rigid vigilance regulation, and that's actually not a perfectly good thing. Some people have a regular physiologic amount of vigilance regulation, and towards the end of the 10 minutes, you get a little dips into stage 1 drowsiness. But there are others that have really poor vigilance regulation, and they can dip into stage 2 sleep within a minute or two. And typically, they end up having nocturnal sleep disorders. Now, we got some eyes open alpha persistence in this case that ended up happening. And the EEG earlier was basically without much alpha. It was relatively lower voltage because this is not turned up or anything, and we've got a mixture of faster and slower content. But as we get into the EEG a little further, the alpha starts to happen, and the person basically is starting to lose a good grasp on being vigilant. So if we map the first portion of this before we really get into all that intense alpha, it'd only be up to about 90 seconds worth of it. And let's make sure we get the beginning all the way back to there. we can take this segment and use it to train the algorithm and clean up the EEG so we're not just mapping eye movements. And again, PCA is the initial one. This is the eye blink. Lateral eye movements here. We had a fair amount of lateral eye movement within the EEG. So I'm going to click on that as well. I'm going to turn off the eye blink and actually scroll through. We'll see that there's times when the F7, F8 divergence ends up being a little greater, where there's actually a little bit more of a lateral nature to the eye movement. Anyway, it's not just F7, F8, and here, for instance, is an eye movement that's largely lateral, F7, F8. We turn this up, you can see it's actually T3, T4, and it's got content all the way to the back of the head. So it's slightly lateralized, and it's a lateral eye movement. If we select the blink and the lateral eye movement together, it takes the eye movements out of the raw EEG, both the lateral and vertical eye movements. So I'm going to clean up that segment that we had, taking the eye movements out. As we flip back through the EEG minus those, we can still see that there's segments that we would like to not analyze because of artifact. We can do a mark artifact, and we usually match up the gain or sensitivity with the microvolt level, and pick any slow waves bigger than 25 and any fast activity bigger than 20 microvolts. We'll catch the biggest of the muscle. I'm going to drop the value to catch an automated way a little bit more sensitively. So if we run into spots where muscle tension or large features pop up that are episodic, it'll catch those. So this will analyze the EEG that we've got selected minus that drowsier portion of it. You can see with the eyes open, there's very little rhythmicity. This is 1/3 of a microvolt. And there was no real organized background activity during that segment. There's little touch of content up near 10 hertz, 9 plus, 10 hertz range. The little bit of mu that happened was slightly faster than that. The right side. So a mu on the right side. This is only the eyes open. We've got eyes closed to look at as well. Treating the EEG equivalently. If you look, the alpha up front is extraordinarily stable. In the back of the head, you expect alpha at 0102. But if you look carefully, this T6 is just got a rip-roaring amount of alpha going on there. So we've got an alpha intensity right temporally. And when you average all that out, that T6 is going to stick out. And you expect alpha at 0102, but you don't expect intense alpha at T6. So that may stick out in a database comparison even more than the 0102. So the z-scores may focus you on this, but you should have seen it already. The other thing that you should be able to see is that in the back of the head, the alpha doesn't always line up. Sometimes the peaks line up and sometimes they don't. But up front, every time you see this alpha, all these peaks are in line. So the alpha, the stability of the phase up front is high, and that's going to give us a hypercoherence. And that usually means an affective regulatory issue. Now, the T6 area is cortically, it's a little spot at the temporal-parietal junction. A lot of lateral eye movement. That they kind of a little peekaboo here. But the EEG here ends up having a nice persistent alpha. I'm going to analyze this with the eye movements left in it, not to take up the time to take them out even. You can see the blinks in the lateral eye movement, F7, F8, FP1, FP2. So the slow end of it is that. But this is the alpha intensity here. And in the temporal area, we have the T6, but we have a slow alpha variant at T6 as well. And the T6 area, let's say we think of alpha as an idling down below 10 hertz. Above 10 hertz, it's a neutral positive perfusion, but below 10 hertz, it's an idling. And we have a dominant alpha that's faster, 9 hertz. It's nice in the back of the head, but the slow edge of alpha below 8 hertz is seen right temporally. And etiologically, we can't say what caused this, but this is a localized area that's not working. It's responsible for social perceptual skills. It's seen in Asperger's, which is now not a category in the DSM-5. It was one of the useful ones, I thought, in the DSM-4, but there it went. Autism spectrum disorder with social perceptual deficits. But it's also seen in reactive attachment disorder. It's also seen in PTSD and significant trauma cases. So the impact on affective perception. This area perceives facial expression, body language, that sort of thing. And the emotional tone of speech, the song of speech. So this area is not working like it should. It has the dominant alpha peak in it, but it has the slow alpha focus in it specifically. Frontally, we saw the coherence. Remember, 0.5 is a rule of thumb being too high, and here we're way high. So affective regulatory issue with the right temporal lobe, that's very common in anxiety, but it's not specific to anxiety. Again, it could just be trauma with an affective regulatory issue. But that's generally what we see here is the affective regulatory issue. Now, it can only go up to 1. When it gets up above 0.8, we almost have to start to think, is it some kind of an artifact? You know, this is so high. And, you know, when we look at the raw EEG, we see this extremely stable frontal alpha. You've got two choices when you see frontal alpha like this. This could be coming, you know, directly from the frontal lobe source of some sort. And given how widespread and in sync it is, that could be the anterior cingulate deep along the midline. But this could also be coming as a field effect from the thalamus, from the posterior projections going in the opposite direction. So if this is a field effect, it would explain how curiously high it is. If it's from the FZ area anterior cingulate, then it means that, you know, you got a cingulate issue. So figuring out the source of this ends up being really important, not just casually, oh, well, what's making this alpha up front, but it changes what you're going to see it as clinically and whether you want to intervene on it up front as a frontal lobe disturbance or not. So we basically know this is about a 10 hertz, and if we model this in frequency domain, we'll call it 910, and see if it looks a little bit better at 1011. Pretty much identical, 6 of one, half dozen of the other. We're going to do a Loretta of the source of this content. The primary source that it identifies in the jump to absolute extreme is the normal alpha generator location for alpha in the back of the head, cuneus precuneus. And posterior cingulate is PZ alpha generator. But this looks like the normal alpha generator. But as much as I trust automated software, I always want to rescale to see if there's a secondary, and here we're getting temporal lobe light up on both sides. But where's our frontal lobe generator? I mean, we could slam this all the way to the extreme, which isn't needed usually to find a secondary or tertiary generator. But we don't end up finding a frontal generator. So the temporal sources are, and the normal alpha generator at the back of the head are what's generating this content, and we don't really have a frontal source. So we've got normal alpha generators for the back of the head, but that T6 that we saw on the surface ends up being an area of concern, and it had a slower alpha focus in it as well. And if we look for the 7/8 source, even without any looking around for various frequencies or various intensity shifts, which we do anyway, it ends up showing that right temporal lobe having the slower alpha in it. So it lights up normal alpha generator locations and the right temporal lobe for that slow alpha focus. And that right temporal lobe slow alpha focus ends up being what I think is probably the area that needs to be worked on to end up normalizing function here, the slow edge of alpha in that area. Now, you can get slow alpha like that from migraine. You can get it from trauma, like physical head trauma. You can get it functionally from trauma as well, like PTSD trauma. Click on that, all the frequencies come back. Anyway, this is the 17-year-old, and it's definitely, we've got that right temporal lobe with the hypercoherent alpha up front, which looks like it's basically just field effect, which is why you get up to the 0.9, which is questionably artifactually high. And it's high because it's a field effect, a generator that's actually projecting to the back of that being picked up front from a deep dipole. So that's my quick look through the second client, and we got about 9 minutes left. We've got the next one down here is, this was sent in more recently. We've got one that was a questionable dementia. They thought that this patient had Alzheimer's dementia. And as we scroll through the EEG here with the average reference, if you look for the alpha frequencies, 1, 2.5, I mean, that's a 12 hertz rhythm. And that's a lot faster than the average for anybody that's being considered Alzheimer's. Alzheimer's, you get a dropping of the voltage and a slowing of the alpha. Now, it doesn't mean that we don't have some intermittent slow content in the temporal area, but we also have a lot of this that's lateral eye movement. So you don't want to mistake lateral eye movement for temporal slowing. So this is an EEG where it makes good sense to take out the eye movement component. And the learning algorithm's just going through the EEG, identifying components that are maximally independent spatial and temporal generators. And once that's all done, they're ranked according to the strength of the component, with the strongest ones on the top. And the chunk EEG was complex. It's taking its time. but we'll end up seeing the results here in just a moment. The topographies will all shift, and again, these real spotty images will end up disappearing. The larger the piece of EEG, the longer it takes, and the more complex the EEG, the longer it takes as well. Okay, it took 624 iterations for it to go through and learn the EEG patterns. And the top one is actually lateral eye movement. You know, eye blinks aren't on the list so much. And the EEG here is an eyes closed, and you get more blinks with the eyes open and more lateral with the eyes closed. So pulling those lateral eye movements out at this point, running back through the raw EEG, and we can see that we still end up with temporal slower transients, which may end up being vascular. And we'll take a look at that. We may have some minor vascular change here. And even though the alpha is really quite fast, a lot of it up front lines up quite often. We'll have to take a look at that. It's not the worst I've seen. It's probably just a touch over the expected norm level, but it's a bit increased in coherence. Let's take a look at the spectra here on this supposed dementia case with Alzheimer's. Now, Alzheimer's, the voltage goes low and the EEG goes slow. Is a 12.2 hertz alpha peak slow? Last I read it, I don't think that's slow. And the alpha range here starts at about 9, maybe 9 hertz, and goes up to about almost 15 before it disappears. So if they call this Alzheimer's, I'm going to suggest that that's just plain out a mistake. Now, it doesn't mean that there isn't something going on that may end up causing some changes here. And the slower content that was present here on the left would be in the word finding, verbal fluency area. And so there may be some changes due to vascular change. But Alzheimer's as a process would be slowing the alpha into the theta frequency band and not be this fast. So this does not look like Alzheimer's. It does look like we may have an issue with respect to vascular sufficiency and maybe a vascular related dementia change over here. It's a bit off. The coherences don't stick up as an isolated peak, but the faster alpha is basically what we're looking at. And we get to just above 0.5 here. So it's a touch high on coherence, and there may be a depression overlay on top of the clinical presentation that's being mistaken as a dementia. And the fast alpha here, SNRI should be avoided because we've got fast alpha, but an SSRI could be considered. DC stim or EEG training to perk up the frontal lobe, and especially to deal with slower content in the dorsolateral frontal areas would end up being of benefit. Anyway, I think I chewed my way through your hour by looking at the little wiggly lines here. We've got a couple minutes left. I'd like to make sure anybody's questions or comments are able to be dealt with.
All right, folks. Questions?
I'm muting a few people here so that they can.
Okay.
Okay, they came in late.
Anyway, that was a quick run through on a few raw EEGs, and I'm sorry the hour didn't have enough time to go through all of them, but I wanted to specifically get to the mistaken probably diagnosis on the 56-year-old with dementia that's being called Alzheimer's. That didn't look correct.
This is Rick. I have a question. Would you clarify the issue of mu again? When you went over the mu, the mu, you said that it looked like that your interpretation was that the mu was disengaged.
Yeah.
What do you mean exactly by that?
Let me discuss that. First of all, mu neurologically is normal. It's seen in large studies of the normal population, neurologically screened, not psychologically screened, but neurologically screened. And about 18 to 20% of the normal population will have an identifiable mu. However, it's seen in ADD, ADHD at about 50%, about 50 to 55% in depression. It's seen about 70% of the time in autism. And when the mirror neuron system is not engaged, mu happens. Very much like when you close your eyes, alpha happens in the back of your head. When your frontal lobe mirror neuron loop, and the mirror neuron system has two loops to it, when the mirror neuron's frontocentral loop is not engaged, mu happens, again, very much like alpha with the eyes closed. Now, the mirror neuron system on the left is responsible for language comprehension. The mimicking of ma, 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 pa, 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 da, da, da eventually starts to mean something. The mimicking is the frontocentral loop. The comprehension is the centrotemporal loop. So the Wernicke area gets integrated with the comprehension of the sounds. On the right side, facial expressions, body language, and the emotional tone of speech are what's mimicked. And that mimicking ends up kicking into the right posterior temporal parietal junction. If Wernicke had a sister who wasn't all left hemispheric language oriented, maybe she would have discovered something on the right side. Who knows? At this point, we're stuck with Wernicke's name on the left. Nobody's claimed area on the right that's the equivalent of it, or emotional comprehension other than language comprehension.
When you see the mu, is that mu showing up a lot, or is it just sporadic?
In fact, when mu happens, the amount of mu will end up usually sticking outside of normal range on a database if it's really truly a big outlier. But when it's present, and you see it on a persistent sputtering basis, you can assume that that network is essentially not fully functional. And you know, the mirror neuron system ends up being a bit controversial in neuroscience because some people thought of it as an actual physical neuron. Oh, well, you know, where is that mirror neuron? In fact, it's a network property. It's not a neuron itself. And they discovered it by sticking an electrode, needle electrodes into neurons, but they were simply neurons that were networked into this system, not that it was those specific neurons, and those were the only neurons that responded to the. So you have to think in terms of neural networks, not not some simple. This neuron is your mirror neuron, and when it's active, and so on. I would urge you to also think in terms of mu being an important feature in autism, because mu has been shown to be decreased with the presentation of oxytocin, which is the social hormone. And they use oxytocin on some autism cases as a hormonal treatment. And it's specifically well targeted for those who have excesses of mu. The development of mu, the meaning of mu and everything is probably best described in a paper by Dr. Pineda, who discovered it in 70% of the autism population. If you don't have his papers and you need them, email me and I'll be happy to forward you his papers, as well as the one on oxytocin and one on the developmental trajectory of mu in human development.
All right. Well, thank you so much, Jay. We're kind of at the top of the hour. And,
yeah, thanks for your time.
Well, we'll have to get you back again. It's great stuff. Thank you very much.
Well, sorry I couldn't get through everybody's EEGs, and that's the nature of time, I guess.
Oh, it was great to be able to watch you at work, Jay. You know, you've got so much knowledge about medical EEG and QEEG. It's just fun to watch you take things apart and come to conclusions. It's been a real pleasure.
Yeah, we didn't even get to do any database playing, so yeah, we were just trying to buzz through these on the EEG part of it.
Well, we don't, you know, so many of us don't get much exposure to the morphology and the side of it that you do. You know, a lot of QEEG often misses out on that, so it's great to have people see what it is.
Well, and there's also people that say you can't see coherence, and I mean, if you can't see it, you won't look for it. But after you see that it can be seen, now you start to look for it. So the ability to actually look for phase stability is there, and if you look for it, you'll see it.
Well, I think that's why it's good for them to see you pointing it out and get clarity on how to look at it. It's great.
Anyway, life's too short. What can I say?
Yep.
We'll catch you all another time around.
Okay, Jay.
Yep, and we'll see you at ISNO.
Actually, I'm not going to be there this year.
You're not? Well, then we'll catch you here.
Catch you maybe at the California Biofeedback Society in November. It's our 40th anniversary. We're going to throw a big party.
All right.
All right.
All right. Thanks very much.
Thanks again.
Catch you all later.
Thank you, Richard, and